Hello, everyone. Good morning or good afternoon. My name is Tracy Cook, and I'm with Saks Healthcare Communications. I'd like to show our audience today how to send in questions, which our speakers will answer as many as possible at the end of the webinar. Please type your questions into the questions box, as well as you can download the handout from the handout section of the GoToWebinar control panel. Our moderator today is James Simmons. Dr. Simmons is currently a hospitalist nurse practitioner at St. Francis Medical Center in Los Angeles. He is also a guest lecturer and research consultant at the UCLA School of Nursing. He is a founding clinical ambassador for the CDC's Let's Stop HIV Together campaign and has emerged as a leading voice advocating for marginalized communities and healthcare. Dr. Simmons is also frequently featured as a health expert on national television, radio, podcast, and social media programming. James, welcome.
Thank you, Tracy, for that very kind introduction. And welcome, everyone. Good morning, good afternoon, wherever you are. So the title of today's webinar is Anatomy of Rapid Response Teams. And speaking today on this very important topic is Dr. Fiona Winterbottom. Fiona Winterbottom is a nurse practitioner and experienced clinical nurse specialist with a demonstrated history of working in the hospital and healthcare industry, skilled in adult health, critical care, palliative care, healthcare information technology, electronic medical record, data analysis, project management, and clinical research. What can she not do? Fiona is an outcomes expert and leader in quality improvement in hospital settings. Very lucky to have Dr. Winterbottom. Okay, so Dr. Winterbottom does have a couple of disclosures for you. She is a consultant with Zoll Medical, Baxter, and Blue Cirrus. So, continuing education for nurses and respiratory therapists, right? It's part of why you're here. So this educational activity is approved for one contact hour for nurses and respiratory therapists. A link to obtain your CE credits will be available at the conclusion of the webinar, and we're going to go over how exactly you can do that. There's a little bit of a process, okay? The accreditation statements are also listed here on the slide for you to see. And a big thank you to Zoll Medical Corporation because support of this educational activity is provided by Zoll Medical Corporation. Okay, I'll be back at the end. We'll go over your CEs and Q&A, all that stuff. But for now, I would like to turn the presentation over to Dr. Winterbottom.
Hi there, everyone. I am honored and excited to be here. This is one of the topics I love to talk about. So I'll try and keep it to about 40 minutes so that way there's time for questions and answers at the end. Let me just make sure I can advance my slides. There we go. Let me back up. So these are the learning objectives for today. We're going to discuss the function and significance of a rapid response team in improving outcomes through resuscitation advanced life support, identifying key training components and workflow definitions for successful implementation, and then exploring the impact of rapid response team on patient care and outcomes. So hopefully that meets with your objectives for today too. So a little bit about why do we even need a rapid response team and what is a rapid response team? So really, this developed out of a need for patients who had a sudden imbalance in their needs and matched resources. So patients who were clinically deteriorating on mostly inpatient floors needed a mobilization of resources to match the sudden demand for their care. And in 2006, there was actually a conference that looked at all of the different components of a rapid response or medical emergency team and really started to put some structure to the program. There had been multiple different papers published about patient safety in the early 2000s to err as human and crossing the quality chasm. And some of those were really led to a more global kind of view of medical errors and medical harm. And so that's where the rapid response teams were really born out of, was a solution to that problem. So There was also some patient safety programs that came out of this in terms of patient safety goals and things like that that were followed up by a variety of regulatory organizations, but they kind of followed this initial document. So what this document kind of laid out were the different components of a rapid response team. And even though it's titled medical emergency team, the difference is a little bit nuanced. A medical emergency team generally refers to a team that has a physician or provider on it, and a rapid response team is really a more nurse-led team. And so this one kind of talks about both within the document. And so they really identified that there were some specific components that needed to be a part of a rapid response system. So it was the crisis detection or afferent triggering mechanism, the efferent, so the response or the response team that came to the trigger or the emergency, a governance arm that really looked at what the infrastructure was like within an organization and how to manage findings from that, and then mechanisms to actually look at what we might find with patients who are deteriorating. So how can we look at early intervention to prevent clinical deterioration altogether? So that really speaks to the components that were outlined in this document. This is another diagram which actually comes from Australia and looks at the slippery slope of patient deterioration. And what we really want to try and do is prevent that clinical decline and intervene as early as possible. So the Between the Flags program is where this comes from. And it's really about, it was named from, if you swim between the flags, you're in the safety zone. And if you're not, then you're out of the safety zone. And so that kind of translated into our clinical setting. And what we're trying to do is not get to the bottom of the slope. We're trying to prevent advanced, cardiac life support and mortality, obviously. But rapid response is kind of a step up from that. Clinical review is earlier upstream than that. And then prevention, obviously, we don't even fall off the slope at all. And so this is where they actually have regulation about this now in Australia. So it's very widely spread, but it just gives a great picture, I think, of what we're trying to accomplish with these rapid response programs. And again, at the side, it has those different components of the program, which are the governance. So making sure that we have all the appropriate roles and responsibilities defined. There is some governance structure that looks at the problems and the issues related to deterioration, that there's a standard calling criteria. So when do you actually trigger? That trigger part of the program is really important, because if nobody triggers that there's a problem, then it's unlikely that you're actually going to catch the patients earlier to prevent them from deteriorating. And initially this was done on paper when these programs started, and now of course we've automated a lot of that. Clinical emergency response systems, so they're the training to meet those needs of the teams that are going to respond to emergencies. So we have appropriate competencies for those responders, making sure that we have an education arm where we look at what people's competencies are, what the characteristics of the patients are, how many patients does each nurse have, like what is the complexity of the patient. That's all important to make sure we have the appropriate education for the staff. And then an evaluation of when emergencies happen or when things don't quite go as planned, how do we actually improve, and then circle that back to educating and response. So now to flip to our American Heart Association chain of survival. You all will probably know that there's an out-of-hospital cardiac arrest chain of survival, and then this is just depicting the in-hospital cardiac arrest program. And again, another really good graphic to show the different components of the chain of survival. So the early recognition, the activation, the actual interventions that we need to try and reduce mortality, the post-cardiac arrest care, and then most recently, they added recovery because we've done a good job with the first 3 rings, and so now, or 3 or 4 rings, now what's happening is we are actually having survival and people are recovering after some of these events. So that's a new component of the chain of survival. We're going to talk a little bit about each of these components. This is a graphic of the Utstein formula. I'm very visual, so I like a lot of graphics because I think they tell stories in, very easily. And so this is really a formula. It's a formula for trying to get all of the components of the targeted interventions we need to move the needle on improvement. And so I highlighted in the red boxes where we really focused for our program. We looked at education in situ. So we tried to do it, in units in areas where the staff were, feedback with feedback devices, and then teamwork and leadership training. And that's where the bulk of our efforts went in the early parts of our program. But again, I will tell you that where you start is not where you finish. And so you can take whatever you already have and you can start to utilize that in whatever way works for you. So this is why I like to show the different graphics, because it could be a different starting place for everybody. So it gives you the opportunity to adapt what you have. And using some lean methodology, Lean Six Sigma methodology, this is just an example of a driver diagram. And sometimes it just helps put things into perspective. So this is one we started with early on with our program. We wanted to improve patient safety and improve that quality improvement quickly, not, we wanted to move it fast. And so the drivers for that, the primary drivers were, we did have unexpected mortality that we thought we could impact. We needed to make sure that we had resuscitation experts available. We wanted to detect and make sure that we could address non-beneficial care. So when we do resuscitation, things that are not helpful to, patients or families. Optimize whatever we could in terms of care effectiveness, and then make sure that we engaged our staff in both their own journey, their own professional journey, but in the patient experience also. So you can see with our secondary drivers, we wanted to proactively prevent failure to rescue. We wanted to try and enhance early recognition as much as possible. And then we had the opportunity to leverage a lot of technology in different ways. And so we were able to utilize that. And I'll show you a little bit of that later. And then for expert resuscitation, we wanted to make sure that all of our equipment could actually deliver the things we were trying to accomplish. We used a lot of simulation and training for staff. We also did some difficult conversations, advanced care planning, types of education also, to make sure that when people did have, that we were appropriately resuscitating people who wanted to be resuscitated and wanted the interventions that we were providing. Then we looked at care effectiveness. So that was all about outcomes. And then did we comply with evidence-based practices and care bundles? Did we provide feedback to staff in a meaningful and timely fashion? And then with communication, how did we communicate and support patients and families across the hospital setting? And so again, just an example where you can put any of your drivers or secondary drivers. They may not be the same as ours, but this is just an example of how you might lay out this program. Since we're talking about anatomy, there's a lot of pictures and graphics. So as we move on, we've now moved on here to, I think 2019, this paper was published. And so now we're at the third consensus conference, and now we've changed that name to Rapid Response Systems. And what happened with this was they actually started looking at quality metrics and how they might standardize quality metrics. And this is an international group that participated in development of this consensus statement. And so what we did at our organization is we took the metrics that they were recommending, and some of them were recommendations, but largely from expert opinion, so not necessarily a lot of evidence behind them, but the only way you get evidence is to actually create it. So we took some of these and then gauged where we were as an organization against the metrics. So I created a gap analysis of what we had, where we were, what percentage had we accomplished, and what did we still have left to accomplish. And again, that was just an Excel spreadsheet with a color map on it. But it does help visualize that idea of where are you on this journey with regard to the guidelines. So we spent a long time. We started our rapid response program, our first one in 2006. I'm in Louisiana, so it was right after Hurricane Katrina, so probably not the best time. But we started the program. It was an ICU nurse that ran around the hospital and helped staff on the floors. We kind of further developed that, but as we got to 2009, 2010, the ICU nurse was actually never in the ICU and was gone for long periods of time. We did not have an electronic medical record at that time, so the nurses were really putting stickers on pieces of paper, and we were aggregating time and energy using, bits of paper. So that wasn't optimal, but it did clearly demonstrate that we needed to change what we were doing because the support for the staff was not there. So the nurses in the ICU felt like they weren't ever in the ICU, and that was where they were actually assigned to be. And then the nurses on the floor felt like the ICU nurses were always running away and couldn't give them the time that they actually needed. So we put together multiple proposals, and just so you know, you don't usually get the first one, so you have to do multiple. And we finally, in 2017, were able to get a 24/7 staffed rapid response team. So this is just a little bit of our kind of reorganization map. We were able to create a task force committee, a resuscitation committee in 2016, which really evaluated all the things that are listed here. It was largely our defibrillators because our defibrillator fleet was at end of life. All of our equipment and supplies, process of care is really our team, and then training, and then data and outcomes. And so I'll show you a little more graphics about that shortly. But we really had teams and task forces that we put together with frontline staff so that they could give input on all of these pieces of the program, so that we could start to move in a direction of, structuring where we wanted to be, later. With the program planning, we did all the things that you can do for free. Like we raised awareness, we did education, we tried to improve our documentation. By 2017, we had gotten our electronic medical record. We got that in 2012. So we had some ability to pull some reports and some data. We had started to use artificial intelligence and some wearable technology. Then we really implemented our team in 2018. And so we did, again, more and more training for both the team, and then actually started with training for the staff, the frontline staff. So we trained we redesigned our advanced cardiac life support training altogether, and implemented that so it was a more hands-on interprofessional simulation type program. Then as we got to 2019, we were really rolling. We were doing great. We were getting some awards for our Get With The Guidelines. We were following the guidelines. We were doing our work there. We also have telecritical care programs, so they were able to help and support the teams, particularly in the ICU. And we started adding more structure to things like written order guidelines, policies, and procedures that needed to be adapted. And then, of course, as we all know, in 2020, that all came to a grinding halt because we had COVID. And I say that in that our training had to come to a grinding halt because we were not able to do in-person training, etc. All our staff couldn't have even got off the units anyway because it was so busy. But what didn't come to a halt was the team. And I'll show you a little bit later some of the data that supports the fact that we had the team and they were able to really mitigate probably some emergencies during the COVID period. So this is our kind of structure. We took the task forces that I just described and we gave them each kind of a charge for what we wanted them to accomplish. So the technology task force was seeking out, novel technologies, and then how could we improve surveillance and care delivery. The process of care task force was the actual team. How did we set up the team? What was their daily work? How did we build the electronic medical record for them? Equipment and supplies is really exactly what it says. What tools do we need? What do we have? What do we not need? So with that, we actually ended up reviewing our code carts and just saying we don't need half the stuff that's in here. There's actually no evidence to support its use, so we got rid of it. We did, as I said, we did replenish our fleet of defibrillators because they were quite old, and so we staged that. We staged that implementation also, which was great because it came with some education for our teams. We looked at all the regulatory compliance that was needed. There was some new documents that came out over the 2016 to 2020 that were documents about new Joint Commission guidelines that were going to be coming out, some certification requirements for resuscitation that came out. There were some articles about time to act, the time is now for cardiac arrest. So there were lots of different documents that we had to try and keep ahead of as we were developing this task force. So we kept up with our evidence-based practices. Then obviously education and training. We did lots and lots of education and training for all the teams, both the primary team, the response team, and the trigger team, the floor teams. We also had residents, fellows, attendings from our different services, hospital medicine, critical care, ED, and then our floors, like all of our specialty services. So they all got to participate in education. And then we did a lot of review of data, trying to really see how we could measure the effect of the program, because as probably most of you know, it's kind of difficult to measure things that don't happen. So we were preventing things from happening. So we had to figure out how to measure that. So as I said, we looked at the early warning systems and rapid response. We looked at the recommendations from the American Heart Association. This is from the 2020 guidelines. They were similar in 2015, but it was a 2A and 2B recommendation for a rapid response team, but the level of evidence was fairly low. So, still needed some work on that, and hopefully we've contributed to that body of evidence now after we've kind of done some of this work. We looked at our dose of rapid responses increased with the implementation of technology. We started to use our electronic medical record. We leveraged alerts. We started to involve our advanced practice providers. I'm one of the critical care advanced practice providers. So we started to figure out how to leverage technology with alerts and things like that from the medical record. So this was kind of, at first, it was our advanced practice providers going to these alert initiated responses. And then we kind of had our nurses assume that role because we actually couldn't supply enough advanced practice providers to do that. This is an example of what our electronic medical record risk stratification looks like. We have patients lists where we have different levels of alerts. So we do use modified early warning score because that was what was in our electronic medical record. So we can screen that way. There are some prompts within the medical record to tell the staff what to do: increase vital sign monitoring, call the charge nurse, call a rapid response. We have artificial intelligence alerts, which is the second column. That just describes kind of the alerts that I just was showing you with the computer and with the watch. And so slightly different, very early, so treated a little bit differently. Muse scores are more timely and later, and the artificial intelligence is really quite early and predictive. And then just a patient list, so we know where the patients are, who they are, and then we have some different types of vital signs. So this is an older one, but we have different columns that the staff can drop in and create their own columns for their own lists as they need them. So we leverage that pretty heavily. We looked at teamwork and leadership training. So we wanted our rapid response teams to be the leaders of the team. This was mostly nursing, so we wanted to make sure that they, there were recommendations, again, low level of evidence, but certainly a high, a 2A recommendation. So we tried to train our staff, lots of simulation. We had some support from external people who had their own advanced cardiac life support programs, and so we leveraged those and really got them to be the experts we wanted them to be. This is just an example of our sim center. This is our nursing team with our physician team and our residents, because our residents were really the backup for a long time, our medical residents. And so it's a lot of active participation. This is one of our rapid response nurses putting a bag valve mask on a person and showing how you can improve PEEP, basically positive airway pressure, and buy yourself some time. But we did a lot of this type of work so that it was actual, hands-on training. It was interprofessional, and it was really focusing on how can we stop the deterioration. This is an example of multiple workflows that we have gone through. I have any number of these algorithms, but this is probably one of our more recent ones, where you can see there's a rapid response provider, which is an advanced practice provider from our critical care medicine team, a rapid response nurse, and then we also have a rapid response therapist. So we currently have 24/7 rapid response nurses, 24/7. We have a rapid response respiratory therapist 7 days a week in the daytime, 7 to 7. And we just added a rapid response provider 7 to 1 Monday through Thursday, because that was our coverage time and it was the busiest time for our emergencies. So we started there, and as I said, you work with what you have, so you just keep going. What we do is we try and have morning reports and look at the patients together. We have slightly different workflows, so everybody's looking at patients that were called overnight and perhaps declined to come to the ICU, but we still need to keep an eye on them. Those are our high risk lists. So whatever list we happen to be using, our artificial intelligence, we now have sepsis alerts, modified early warning scores, and then phone calls for a consult, or calls from staff to review patients. We also have a lot of oversight in the emergency department for our patients being held, which is, a big topic of conversation currently. So we also look at those. We try and do the proactive screening. So the blue is the screening. We screen using all of those tools. Once we've screened, we go to the who needs to actually have a patient visit. And then if there's an emergency, then it's paged out or overhead paged, and that's how we all meet together for those more reactive emergencies. So again, this is not where we started, this is where we are today, and we just keep iterating this process. But it's how you get good at doing this. And so I think we've learned a lot, and hopefully this is helping you guys learn. This is an example of a kind of upgrade. We called it the upgrade process detail. What are the actual things that have to happen if there's a deteriorating patient? So the primary nurse calls the team that owns the patient, so the primary team, that the nurse's job is to call them. The primary team then needs to come to the bedside and evaluate that patient. At any point in time, any of the teams can call for a rapid response nurse to come. And then when all of those people are at the bedside, you have to decide, what is the next plan of action? What does the patient and the family want? What interventions do they want? Has it been discussed before? Does it need to be discussed now? So what are the goals of care? If they are to maintain the patient on the floor with, more medical interventions, not invasive interventions. If it's a higher level of care that perhaps doesn't require ICU, maybe it's a drip or something that can be done on a step down floor. Those who are likely to benefit from aggressive interventions, they're the ones that we would move to the ICU. So there would need to be an ICU consult, and then we would move the patient to the ICU through that process. And I put this slide in because we adapted this with COVID, because we had a lot of patients that needed the extra oxygen. And so obviously everybody couldn't be in the intensive care unit. So we started to triage, and it's just an example of how you can adapt what you start with to decide where you want patients to go. We also had to define all of the different things that we were doing. So as we talked about the screening, the rounding, we had to really define what those were, because it can get quite complicated if people don't understand what you're actually trying to accomplish, because you have so much either turnover or change. So the screening was really that reviewing those patients. The proactive rounding was to try and get to the bedside within 4 hours of getting any of those alerts or high risk alerts. Rapid response, the expectation would be to be at the bedside within 10 minutes. We have 16 floors at our hospital, and we cover a quite large campus, probably about 3 city blocks. So it's quite a big campus to cover. And the reason that we made it 10 minutes was because sometimes you're already in one emergency and you call to another one. So we did have to create multiple backup systems for that. And that's how we actually ended up with 2 rapid response nurses. Cardiac arrest, we say 5 minutes. We're usually there in 2. But again, if you have elevators and things that you have to navigate, then sometimes, you could be in another event. And then we really wanted to try and focus on debriefing and case review in the moment, so that we could try and support the staff and help them, grow and develop. In terms of treatment recommendations and recommendations from the AHA, there's one on feedback. And so we have heavily leveraged our new technology here. And we started to use our defibrillators, which had our feedback in it. And so that was super helpful in terms of giving staff feedback, both in the middle of an emergency, but also afterwards. This is a nice little picture of all of our different technologies on one page. And then at the bottom, that's one of our nurses who's in our tele ICU, who can see multiple screens. I think that shows 6, but I think we have 9. So they can see multiple things at the same time, and often act as a co-pilot and coach to make sure that people know what is happening in the room. So that's been super helpful. They do 99% of our documentation for code documentation within the medical record in our ICUs across our system. And then this is an example of how we review a case. We have a feedback summary that comes from our defibrillator software. We can look at what our chest compression fraction is, what our time off the chest is, what time we turn the device on, what time we turn the device off. And so this has been really helpful in providing feedback to staff. This is a more detailed version of what we can also get from the device. So we can annotate it both within the device, or we can just write on it. You can see at the top, there's the yellow bar shows the CPR, and then it shows a defibrillation is the little lightning bolt. It shows you depth and speed of compression. So blue is good. So this is just an example of where we were giving CPR reasonably effectively. And then it shows you recoil also, which is towards the bottom of the screen, and that just can help identify where you might be leaning on the chest in a CPR event. And usually you can also see when people are getting tired. And then at the very bottom is the ventilation performance and end tidal CO2, which we actually use for goal-directed resuscitation. There's also a piece of that software that shows you the actual rhythm of the patient. And so that's been really helpful when we're looking at our Get With The Guidelines data to see, did we meet defibrillation in 2 minutes? We can actually see all of that information, and the end tidal CO2, which is the confirmation of the airway. So both of those have been really beneficial. So again, going to the debriefing, it really is helpful to do this in real time or as within the shift if you can. And so there's definitely some, data to support this. Again, a 2A recommendation with a level of evidence B. So trying to utilize this for staff feedback, but also staff support, because it's probably the worst shift of your life when somebody, codes on your shift. So we want to make sure that we're supporting those, those staff and looking at ways that we can do things differently. We do cold debrief, we do hot debriefing, which is right after the event or shortly after the event. And we also do cold debriefing, which is usually about a week later and more of a high level overview with our performance improvement teams. So a couple of different levels of debriefing. This is kind of a summary of all the different things that we did, again, just for your reference, so you can see that we started in different places. We started our training, we implemented the team, the nurses, we deployed a whole fleet of defibrillators, and we have 110 defibrillators on one campus. So we have a lot of defibrillators. So it wasn't a buy them all at the same time. We had to kind of stage that. And we used the education that came with them to help with this program implementation. And then we became more structured in our case review process, the one I just described. For COVID, we did add a third nurse because the needs were so great for the support by the staff. We didn't know what the disease was. We weren't able to get into rooms fast enough. We heavily leveraged our tele-ICU. And so we really needed that extra support for the staff during that time. And then since then, we've initiated 2 or 3 programs in community facilities. One was done during COVID and one was done in 2022. And here just a little bit about outcomes, which nurses don't usually like graphs, but this is just a longitudinal view of our program over time. There's some peaks and troughs here. Some of it was where like 2013 was where we were implementing our medical record. Some things were on paper, some things were in the computer. But what you see is that since we implemented our program in 2017, beginning of 2018, our codes per 1,000 patient discharges have decreased, rapid responses went up, and now we've been doing more proactive rounding, they've actually come down. This is just the 2017 to 2020 with our COVID. So you can see the big drop that happened in our cardiac arrests outside the ICU. It was a pretty significant drop. And we maintained our critical codes outside the ICU is the red, and the codes inside the ICU is the green. But what we wanted to make sure is we didn't just move one problem to a different place. So we just moved the problem from the floor to the ICU. The only time we really did do that was in COVID. And so that's where I think it's really important to show that we were able to still maintain that even through the chaos of COVID. People always ask about productivity. I'm the queen of counting things. So here is just a kind of all the different things that our rapid response team respond to. And so again, just a snapshot in time of how we measure how many events do they go to, how many upgrades do we have. everything is based on notes. They write a lot of templated notes, and we can pull those notes into an electronic report. So, and we match it with what we were doing on paper, and it's pretty similar. So it gives us the ability to provide data to our executive leaders. Oh, that was to show you there were a lot. This is a dashboard that we used for a long time, which just looks at risk-adjusted mortality and the index. So the observed mortality, the expected mortality, and what's the difference in the patient populations that we are actually serving. So of patients seen by the rapid response team, how does that look in terms of risk-adjusted mortality? And what this shows is, even though the yellow line looks really flat, which is the index number on a linear graph, that big peak in April of 2020, it was March actually of 2020, is where COVID hit New Orleans. But we actually managed to keep the actual overall mortality index stable despite all of the increase in the number of visits. So the blue lines are the visits, and that's how many visits were made to staff. And so you can see we were doing a lot of visits also. But again, just a way to look at outcomes and how to display outcomes. We kind of looked at dose of rapid response. Dr. Michael David has done a lot of work on this with doses of rapid response. And what we found was that there was actually you could see if you had a certain number of encounters, you could see that risk-adjusted mortality changed. And so what we call that is the optimal dose. And so each program will have its own type of optimal dose, but we wanted to really look at it to demonstrate the value of the program. So this is it in a graphic format, which I think is easier to look at. On the left-hand side, you can see the risk-adjusted mortality index, and it was 2.4, and then the number of encounters. So that's rapid response, proactive rounding encounters. And as you see more dots, because there's more dose, you actually decrease the risk-adjusted mortality. So just another way to visualize the success of the team. And we kind of looked at it at about 150 encounters per 1,000 patient discharges. That's where we landed. We tried to look at a cost analysis for the program. We were given basically $500,000 is what it cost to initiate the program. When we looked at the cost per day for patients, we looked at just simply the bed cost, and we looked at what a non-ICU cost was, what an ICU cost was. We looked at the number of patients who we had to intervene on, and then the difference between that cost essentially, and looked at a 10% reduction. So if we assumed a 10% reduction in transfers to the ICU, each patient was 6 days in the ICU if we upgraded them as an average. So that would basically give us a cost avoidance just for bed days of about $500,000. So it was about what we cost the program. That does not include all the extra imaging, labs, medications, all the other things that go with an upgrade to the ICU. So it's probably more than that, but we at least could demonstrate this fiscal benefit. This is just a new paper that came out in November of last year that really quite nicely pulls together all the things that we did into a nice little document. I wish I would have had this document 10 years ago, but anyway, here it is for you. And so I would definitely push you to look at this document. I think it will be super helpful for you. Great guidelines in there and really help you build a program. And finally, just a couple of other data slides to show you our proactive rounding. So as our proactive rounding in the green went up, our cardiac arrest per 1,000 patient discharges went down, and so did our rapid responses. So that's what we wanted to see. And then this is one of our community facilities. We saw a similar effect there. And then they actually had data on the patients that were transferred to the ICU with proactive rounds and with rapid responses. And the big spike is when they initiated their program completely. So they had a big surge of lots of proactive rounding. But it really shows you that they were able to, the yellow is the patients that remained on the floor after a rapid response and a proactive round. It really shows you the ones that we kept out of trouble and didn't incur that extra cost. So again, hopefully helpful in terms of visualization of outcomes. And so this is our team when we got our first Get With The Guidelines Silver Award. We're now at Gold, which is great. This was the team that started it all, so I wanted to recognize all of those and our CNO that supported us in the program. And I will turn it back to James.
Wow, Dr. Winterbottom. Okay, that was a lot. I was like fascinated the entire time as someone who has been a part of rapid response teams, both as an RN and then as a hospitalist nurse practitioner. So I had a bunch of questions. So do a lot of people. So we're going to get to those, I promise. We're going to try to get through as many as we can. But first, I need to tell everyone about how to get your credit for this, of course. So continuing education for nurses and respiratory therapists who are on. It's approved for 1 contact hour. I'm going to spell this out for you because it's kind of important. You got to go to www and you got to put the www in. www.saxtesting.com/rev, R-E-V. www.saxtesting.com/rev, R-E-V. Once you get to that site, you'll have to register, complete the evaluation form, and then you'll be able to print your certificate of completion. Okay, so that's how you get through that. Take a snapshot, download this, screenshot, whatever you need to do. And again, a big thank you to Zoll Medical Corporation for support of this educational activity. There is also an archive version of this fantastic presentation, so you can get all that yummy, wonderful, juicy data and all those graphs. And I am a graph person, Dr. Winterbottom, I loved him. The archive on-demand version is available at www.revive-now.org. www.revive-now.org. That version is accredited for nurses and respiratory therapists for that 1 contact hour. So never fear if you missed something or folks aren't in the room right now watching. Okay, so we right now have about 11, 12-ish minutes for Q&A. So Dr. Winterbottom, are you ready?
Ready.
All right, so the first one, I love it. You're like, let's go. There were quite a few questions about data. And so I want to get your brain starting to think about that, particularly in terms of the data, not only your collection process for this, but how that data compared to other rapid response team initiating programs, regionally, nationally, internationally, et cetera. So data in terms of how you collected it, who was responsible for that data, and then part 2 of this question, Dr. Winterbottom, is how does that data compare to other rapid response teams in hospital systems of similar sizes, similar patient populations, and where can folks find that information? All right, did I throw too much at you?
Ready, got it. So
Awesome.
the how is, I told you we started on paper, so that was stickers on pieces of paper. That was in the early days. We moved to our EMR in 2012. So we had a little bit of a lull, which was a combination of what you put in the computer and what you don't. We then used reports that we built within our medical record to pull the data back. Of course, that means you actually have to have documented something, so to get the data back. So we initially had built our own flow sheets within our medical record. Then there was a change in how that data was collected, kind of from the vendor. And so we then ran reports from that program. Again, you've got to have done the work to be able to, and documentation to be able to pull that. So we did that. We also used our defibrillators because that also tells you if you've had an event. So we were able to pull that for our resuscitation events. So that's the how we got it. A lot of it's automated, but it's still manual in terms of you have to do some, tweaking of it. Who pulled that? That was a lot of me. That was a lot of me doing that initially. Now we have also our performance improvement team help pull that because it's a little bit easier because it's automated. And we, with the compare part, that kind of rolls into the compare part, which is where do you put that data? So we had an internal database, which was just an access database at the beginning. We did participate in NRCPR, which is now Get With The Guidelines resuscitation. And so that's where you can start to compare your data. It is a lot to put in. And so I'm sure there'll be questions about how do people do all that. We do not put our rapid responses into that database at this time. The caveat to that is I built special notes within our medical record that captured data. So I can pull a note on, I can pull all the notes that our rapid response team write, as well as all the notes where documentation lives, so that we can pull out smart data elements and run reports. So some tech there.
For sure. Several people actually asked what EMR you use to do all of this.
We use Epic.
Epic. Okay, there you go. For the folks who asked that question, very good. So I'm going to kind of stick on the data throughput line, if you will. Several questions about, okay, we've collected the data. Who is analyzing it and what group of folks are making decisions based on that data? So does it run all the way up through the C-suite? Do you have a specific, and you kind of mentioned this before, but do you have a specific committee that looks at this? How is that committee reviewed? How are decisions about, the additional staffing that you had, the full-time people, et cetera, for the rapid response teams? How is that decision made based on the data?
So a resuscitation committee. We had a resuscitation committee, and then the task forces fed up to the resuscitation committee. So that's how it all really got moving, because we would have all of those different groups come. So like our different task forces came to the resuscitation committee with their, wins, limitations, barriers, and at that resuscitation meeting, we're not only clinicians, but they were also quality improvement, performance improvement, people who could help remove the barriers that we had. And so if we needed more executive, we have executive leaders like AVPs, VPs, but if we needed things to go to like the chief nursing officer, then she had an open door for us to bring that information.
Excellent.
And we had physician and nursing leadership support, so it was both.
Well, that's good. There were a couple of questions here as I'm reviewing my questions on the interdisciplinary aspect of this. So you spoke to that a little bit in the presentation, but if you could just expand just a little bit in terms of the decision-making process in how the team is structured and formed, how they continue, the 10-minute timing on what they're allowed to respond to, those things. What is the interdisciplinary nature of how those decisions are made?
So if we're talking about overarching in the governance part, we have a medical director for resuscitation who reports up through our quality department and our vice president of medical affairs. We have a nursing component, which is really the team and the things that happen in the units, and that's kind of our nursing structure. So we have a nursing director who is one of our ICU directors, but has a stretch assignment that she never left, right? Mind you, she's still got the stretch assignment. She is also the director for the rapid response team. We also have a supervisor for the rapid response team that is more of a day-to-day person. So she's the supervisor. We started with just having ICU nurses be the people on the 24/7 team, but we have since, in the last year, we have dedicated people, but all of the people that serve on the rapid response team, I think we have 8 right now, all do shifts in the ICUs to maintain competencies. And we have 4 ICUs: cardiac, medical, surgery, and neuro.
Okay,
So they
very
do
good.
all of that. So that's from that side. And then in daily decision making, so like patient care, the primary teams, let's say hospital medicine, are responsible for their patients. The nurses call them. That's the call escalation strategy. If they call rapid response and the rapid response nurse needs a provider, right then, right there, they don't have one, they call the critical care medicine team. And that's the team I work on.
Excellent.
For provider backup.
That's the response. Now, there are kind of 2 buckets of questions we're going to get into here in the about 4 minutes we have left, everyone. So if you've got any other questions, I mean, there are a lot of questions, but if you've got any other questions, you think you've got a good one that can rise above the rest, drop them in there, because I'm reading these live as we go. So kind of an FTE question. So several folks are wondering, this is another 2-parter for you, Dr. Winterbottom. When you created this RR team, did you lose FTEs from the ICU? Or how did those FTEs come about, if you can walk through that a little bit? And then the second part of that is lots of folks are wondering, what is the rapid response team doing when they are not rapidly responding? When they do not have a rapid response to worry about? Particularly respiratory therapists have answered this a lot. What are the RTs and the RNs in particular doing in between responses?
Yeah, so let me try and answer real quick. So the rapid response nurses were already doing the work. We had an ICU nurse who was already the person who ran out of the unit. They just were not named an out of the unit nurse. They were an ICU nurse that went on the shift that was never in the ICU. So that was really a little bit of a no-brainer because they were already doing the work, just not named work. The second nurse we got, because we were not really doing a good job with managing our resources, we'd have a stroke nurse and a STEMI nurse and a sepsis nurse. We had all these people, so we just put them together. And so that second nurse was actually our stroke nurse. That's how we got our second nurse. Our therapist we actually got because the way that, as we looked at our codes and reviewed them, they were nearly all respiratory. So that was kind of a little bit of a no-brainer. How do you stop respiratory arrest? Well, you may need a respiratory therapist for that. So that's how we kind of, and that originally came out of the respiratory therapy department, but has since transitioned and now lives in our rapid response cost center. We created a cost center for those other people who were asking about FTEs and money. Everybody lived in their own unit. So whether they were medical ICU, cardiac ICU, they all lived in their own unit, but there was a money pot or FTE pot of that people were paid from for those shifts.
Okay, very good. Now, speaking of money, we've got about 90 seconds left or so, maybe 2 minutes. Speaking of money, lots of folks are wondering, where did you get the funding to develop all of this? And if you might need to go a little bit back into 2017 or so, but where did you get the funding for this in particular to develop this team and then continue to pay for it?
So the development was everybody's time who was already doing it as a hobby. We call it the hobby people. They like to do it because they just think it's important. So we were all doing this as a hobby. So that was an unpaid extra benefit of our employment. So we were already doing it. But where the actual funding for the nurse came from was that we implemented all of this technology, and we really had alerts going off that were not properly being addressed. And so our chief nursing officer really was supportive and said, we cannot be having alerts and people at risk and nobody looking at them. And that's what happened. So that's how we got our little money pot.
Well, yeah, and you said some of this before too, but there really is a compelling, I know this is going to sound a little awkward, because there's always a compelling human reason to do this, and your data very clearly show the fantastic outcomes from that. But there's also, for the executives listening or the people running these hospital systems, there's a business case for this for sure. And so in my very last question, you've had several people ask if you individually are available for consultation. Can people reach out to you for some guidance in terms of them trying to develop rapid response teams in their own institutions?
Yes, they can. I think there's a lot to be done. So plenty more work needed.
Excellent. Very good. All right, with that, thank you for everyone's questions. I think I got to the bulk of the sort of the themes of all of the questions. If I miss yours, I sincerely apologize. But at this point, Dr. Winterbottom, thank you. That was really, really fantastic. Truly appreciate it. And at this point, I will turn the presentation now over to Tracy.
Thank you, James, and thank you, Fiona. We'd also like to thank everyone for attending this webinar. We will have a survey immediately upon the conclusion of this webinar. You will be presented with an online survey, so please keep your web browser open, and we appreciate your feedback. Again, the CE Certificate of Completion, in 1 hour following the conclusion of this webinar, you will receive an email with instructions and this link to obtain your CE credits. Nurses and RTs, that's www.saxtesting.com/rev. And that concludes our session. We hope everyone has a great rest of your day.